Okay, I think we are set, and that gave an extra minute for some more PCAG members to join us, which is great. Yeah, so as we put in the agenda, the main agenda item tonight is going to be talking about the FY25 hospital budget guidance, but first I'll hand it over to Susan to walk us through letting PCAG members say hi and share any updates, and I think Susan had a couple things to mention too.
Great, thank you, Julia. So welcome everyone. Happy spring. Today might be the first day of spring. I can't keep track. So what I thought we would do is go around for PCAG members. I can call you out. That might be the easiest as I see you on my screen. And if you could each introduce yourselves, where you're from, if you're practicing, your place of practice, and then any updates that you want to share now. And if you have something bigger, then we can get to it after Elena's presentation. But if you want to tee something up for later, that's fine too. But we do want to have the opportunity to have you guys give us some updates. So let's see. On my screen, I see Eileen Murphy first.
Good evening, Eileen Murphy. I'm a family nurse practitioner, Orange County, primary care, all day. That's what we do.
Any updates, Eileen? And it's okay if you don't have any. I guess not. Okay, my next one is Elliot Rubin.
Hi, Elliot Rubin. I am a retired pediatrician, being in practice for 36 years. I'm in Plymouth, Vermont, and no updates.
And then Carrie Wolfman.
Hi, everyone. I am a family doctor in Brandon. I've been in the same practice for 26 years and still work there Tuesdays and Thursdays seeing patients, which I love. And I'm also the Chief Medical Officer at One Care Vermont. I think if I have an update, it is that I may be getting in touch with some of you or your friends and colleagues next week to talk with you about some additional work on quality metrics between now and the end of the year. So a specific ask and specific data that we want to share related to patient panels and how those are performing on certain quality metrics. So thank you.
Great, thank you, Carrie. And then I have Michelle Wade next up on my screen.
Good evening, everyone. Michelle Wade, acute care and primary care adult geriatric nurse practitioner, currently working at Gifford as a hospitalist in Randolph, but I live down in the Rutland area. I'm also involved with the Vermont Nurse Practitioners Association. The only update I have is that if you have nurse practitioners that are in your organization, we are doing a membership drive. And so if they are interested in joining Vermont Nurse Practitioners Association, have them reach out to myself, Eileen Murphy also, and we will be glad to introduce them to the organization and hook them up with a free membership to get them going.
Awesome. Great. Spread the word. Okay, and I'm going to pronounce your name wrong. Dr. Florence.
When you said that, I was like, I bet it's me, Amelia. Again, ignore the J.
I'm sorry.
No, ignore the J, which you would never hear with Amelia. Fellow Gifford employee with Michelle. I am the clinical coordinator of primary care. I mainly work between the Berlin Clinic and Randolph. And if Michelle can ever actually get me to agree, I sometimes help out in the hospital side as well. So.
Great. Thank you, Amelia. And I see next Tim Tanner.
Hi, Tim Tanner. I'm Med Peds, primary care. Worked, past tense, at the Danville Health Center for 30 years, part of Northern Counties. I continue to work part-time as the medical director for Northern Counties, which is the FQHC based out of St. Johnsbury. And I do have I hope John King joins us because I do have an ask, which is to consider the Maple Mountain Consortium factoring into hospital budget talks and how hospitals can support that proposal for FQHC hospital dyads to have a family practice residency program.
Perfect. Okay, duly noted. Okay, the next one I see is Lee Lopresti.
All right, Lilo Presti, family doctor from Danby, or live in Danby. Still working on opening my DPC practice, but that should be done in 2 weeks or so, I hope. And I'll be back to practicing medicine, which will be great because I miss it terribly. That's my only update, is that I'm going to be a new practitioner.
Great, congratulations, thanks. And then Faye Homan.
Ray Holman, family medicine in Wells River. Had a rough day full of sad patient things and IT problems. So that's all I'm going to say.
Oh, sorry. Rob Penny is next on my screen.
Hi, Rob Penny, family medicine doc. Mostly retired after about 33 years practicing in Burlington. Now doing some volunteer work at the People's Clinic in Barry. No updates.
Okay. And last, but on my screen, but not least, former Green Mountain Care Board member and good friend, Alan Ramsey.
Hello, everyone. Yes, I'm Alan Ramsey. I'm the medical director of the People's Health and Wellness Clinic. And thank you all, well, including Rob, for volunteering to take care of those who are most in need. And my only update is that we continue to hope that practitioners throughout central Vermont, Washington, and Orange County will accept new patients, even if they are on Medicaid, so that we can continue to care for those who really have no other options, including the uninsured.
Thank you. I don't think I missed anyone, Julia, did I?
Everyone having cross-referenced my list with who I see, I think we covered the PCAG members, so
Great.
thanks.
And then why don't I have members, so people from the Green Mountain Care Board, and then I have a couple of updates. So Elena, why don't you start? I know you'll introduce yourself when you do your presentation, but.
Yep. Elena Barabee, Director of Health Systems Finance and Policy at the board. So I'm leading the hospital budget review process with the finance and legal team and other folks at the board. Thanks.
And then Dave Merman.
Hey, Dave Merman, I've met you. I think many of you have met me virtually several times, but I'm a board member in an emergency position at CDC.
Your connection's not great, Dave. Again, sorry.
Connection's not great. Please back work on that.
Okay. Dave's an ER doc, EVMC, and a board member for a couple of years, year and a half. And then Owen.
Is my audio okay, Susan?
Yours is okay, yeah.
I'm Owen. I'm the chair of the care board. Dave and I actually started the same day. I've gotten to meet a lot of you, and thanks for taking the time to help us today.
Great, thank you. And then a couple of folks who are here, Stephanie Winters, why don't you introduce yourself? Might be calling on you for some legislative updates, but.
Sure. Stephanie Winters. I am the Deputy Director of the Vermont Medical Society and the Executive Director of the Vermont Academy of Family Physicians and the AAP Vermont chapter.
Great, thanks, Stephanie. And I see Devin Green. Hopefully you can get off mute, not to put you on the spot. There you are.
Devin Green with the Vermont Association of Hospitals and Health Systems.
Great, thanks for joining us, you guys. So my quick updates are legislative, mostly. H766 passed the House. That is a giant accomplishment from the House Healthcare Committee. from folks on this call and looking at Stephanie and others, it's a prior auth bill, and it hopes, I think the goal, and I do not know all the particulars. I haven't been following it as closely as Stephanie, but it does, I think it will make an impact in reducing administrative burden. Let's see how it does in the Senate, fingers crossed. Stephanie, do you have, or Devin, do you have anything else to add on that? Is it
I
pertinent?
would just add that it passed 137 to 0 on the House floor. So that is huge.
Wow.
So something to be proud of. I know a lot of you wrote and called and testified. So big, huge thanks to all of you.
Well, and if some of the members who've been here for a while, this is why one of the reasons why this group was started was because of administrative burden. And that was, I think, like 2017 or 18. It was a while ago. So, wow, that's fantastic. And then the other bill related to the Green Mountain Care Board, and also, you know, if it passes and if this can be done, it's S98. It's really rate setting for prescription drugs. It was a bill that was introduced by several senators, and they've asked the Green Mountain Care Board to start the work on looking at setting an upper payment limit for prescription drugs eventually. So a ton of work involved. We'll see where it goes, but we'll keep you updated. It's also an important, very important issue for all of you, I'm sure. I don't think there's anything else, Julia, legislatively. No? Okay. So why don't we turn it over to Elena?
I've got a hand
Oh,
up though,
Alan.
Susan.
Sorry, go ahead, Alan.
Yes, thank you. I noticed that the deadline for the CMMI application for AHEAD was on Monday.
Yeah.
And I noticed also, Stephanie, you could fill us in about where AHEAD went on a legislative model, because I think that there is some real benefits for primary care in that initiative. So where are we at in terms of AHEAD? We heard from Pat Jones. I've been following it. Where are we at?
Do you want me to reply, Susan, or?
Sure, you can, and then we can add, but sure, that'd be great.
Okay. So Alan, as far as I know, they did apply on Monday. They were working the deadline, and so I believe that application went in. I like your enthusiasm. I think there's a difference of opinion as to what the AHEAD model will do for Vermont versus what we're already doing. So it will remain to be seen. There was no legislative action on that. There was if anybody read Digger, there was a bit of drama around S-151, which actually started out as a primary care support bill and ended up being this vehicle for a lot of drama between a lot of different organizations. So I'll just leave it at that. And it went nowhere. It did have some intent language that they thought they needed, but they didn't really. And so I think the application went in, and now we wait until I think May is when we hear whether we got it, and then we'll have to figure out as a state. I say we probably have very little to do with it, but you know, whether we'll accept the award. So that's all we know at this point. That's all I know. Others can chime in.
Thanks.
Thanks for bringing that up, Alan. Yeah, and probably in future meetings, like in a couple of months, we'll share with you how the board is, you know, looking at the AHEAD model. Because I know over the next couple of months we'll be, and beyond, we've been learning from Pat Jones about the model, and we'll keep you updated, and certainly would want your input for the board. So great. Anyone
And
else?
Susan,
wanna
if I
add
could just
anything? Yeah,
Yeah, I was just gonna piggyback on that. I can send it out to PCAG in an email afterwards,
Okay.
but there was a press release from the Agency of Human Services about the AHEAD application
Perfect.
that came out on Monday, so we can share that.
Great. Thank you.
And I've been going to a lot of those meetings that Pat's been having on some of those, and I think a lot of the things that we have brought up, also the other providers that are kind of outside of this that are a part of the questions about the AHEADs, they're bringing up very similar. So they're definitely taking consideration. I think everything that we've mentioned to Pat in the past. So it's still a lot of information and a lot of unknowns since it involves, I think, the governments.
Oh, and you've politely raised your hand.
I was just going to put in a plug for feedback on what people are concerned about or really like in the AHEAD model. If you're doing that with Pat, if you're able to CC the board, we're about to enter the negotiation period, and having, as broad of a spectrum of views as possible, I think would really help us in negotiating it. The board is also going to be evaluating it, and in our evaluation, we'll do a lot better if we understand the view from primary care, which is, we really need to support at this time. I met with the VAS, the hospital board, yesterday and asked them for the same thing, as much feedback as possible to help us make informed requests in the negotiation process. So please speak up as much as possible. We really appreciate it.
And we'll follow up too with our portal for the public comments, or you can just send them that would be great if you could just send them right to Julia. But we'll follow up. Go ahead, Faye.
I just wanted to say that through this group, another group that I am on an email thread about that's interested in single payer, some conversations with legislators, and when I was there this past week, I've talked to some people from Green Mountain Care Board or people who work closely with Green Mountain Care Board. Everyone I talk to has a very different take on what's going on with the AHEAD model. And I've literally heard people say one care will go away if it comes through. I've heard people say Green Mountain Care Board will go away if it comes through. And I've been to the presentations and I've listened and I take notes and I try to pay attention and I have higher education and I don't know what to do. I don't understand how to get real information about the AHEAD model.
Thanks, Faye. I see Paul Rice. Oh, go ahead.
Do we have an answer? Do we have an answer for that?
No, I don't know.
I will. That's what I said. Nobody.
I think the
thank
answer is
you.
we don't have enough details to make any kind of educated evaluation.
Sorry, getting a lot of background noise.
I've been going to many of the AHEAD global budget meetings, and I think the reason why we don't really know the answers to things is we don't really know the answers to things. It's the methodology is not set. This is kind of the process unfolding. The application, I think, laid out and will probably become, it's confidential right now, but hopefully will become non-confidential at some point. A lot of the general guardrails and perspectives and governance. So it's really just unknown, which is part of the challenge. It's in process and it's working through the process. But yes, perspectives would be very helpful.
So one thing in addition to what Dave said is tomorrow, I think we have an internal board meeting to come up with a program to educate the board on what the AHEAD model is specifically and where it's at. And we'll be planning board meetings tomorrow for that process. As you all know, Dr. Ramsey must know really well, we can't all meet as a group. So 2 people, Dave and Robin Lunge, have been leading the tag work for the board, and then they have to bring it back to the rest of us. So that process is about to be set up. And I think if you want to learn a lot more, that will be a good opportunity when we have those public hearings. And we've had Pat Jones in at a bunch of our own meetings so far to get us kind of up to speed, but there'll be a lot more getting scheduled pretty soon.
Yeah, I have my hand raised. I'll lower it now. And I agree that the devil is in the details, and it will be for quite a while. And so my interest in AHEC really has to do with where we are now in terms of primary care recruitment, primary care reimbursement, primary care simplicity. We did make a few steps in terms of prior authorization. And that's where my focus is where we are now, where we were 5 years ago, where we could be 3 to 5 years from now. So that is my interest.
That's helpful. Thank you, Alan. Anyone else? Any other questions? I did want to just call out Paul Rice, who joined a little late. Paul, if you can just introduce yourself real quick, and if you have any updates for us.
Yeah, hi. Thanks for recognizing me, although I'm not sure what kind of updates you're looking for.
Oh, just anything.
Yeah, I mean, I think as in the dark, or more so than Faye is. I don't really know where to get information. I'm not part of any group or providing any input, nor am I getting anything. I don't know who is providing the input on it. I'm curious, though. I know that the AHEAD model seeks to involve other payers, to make it more of a multi-payer experiment. Can it be confirmed that other payers, meaning commercial payers, were part of the application process, or perhaps they don't have to be?
I can answer that. Yeah. They did not have to be part of the application process. So to get the application in, we did need a letter of intent from a hospital. 2 were received, one from Rutland, one from UVM. If my memory serves, I think Blue Cross Blue Shield may have submitted a kind of voluntary letter of intent. I know that was discussed, so I think they did, but they did not have to. And then I think in Act 151, the bill that had been in Senate Health and Welfare, there was some language about whether or not insurance companies would be expected or pushed or whatever it might be to participate. But as I understand it, that bill didn't get out of that committee. So I think it's open-ended as to what the participation would be from insurers and or whether it's voluntary or mandatory.
Thank you, Owen. Is there part of the application? I think the sense of, would one care go away? Would the agreement keep it really is sort of seeking the question of who would be the decision makers if the AHEAD model was obtained? Would it be Agency of Human Services? What kind of, presumably in the application, some kind of a structure of a governing body over the model was submitted. Is that something that can be shared, or?
Yeah, I think right now they're evaluating whether or not the application can be public. I'm not sure if it's part of the negotiate. So I think that is all kind of happening right now. And if it is, we'll let people know. In terms of the governance, I think some of this is to be determined, whether or not, there's an equity piece, there's an evaluation of the model piece, there's a regulating of hospitals piece. There's a lot of different components that need to be figured out, and I think that's still being under discussion right now. In terms of like the ACO going away, what I can tell you is my understanding is that the ACO would not be part of this model. That doesn't mean necessarily that it would go away, but that model is not in the offing right now. In terms of the care board, I don't understand the AHEAD model to be doing away with the care board. To the contrary, the NOFO requires the care board to review and sign off and sign the agreement. So I don't see that as part of this either.
Terrific. That's very helpful. I think, to Alan's point, the devil's really in the details of this. It's really, there's wiggle room in this model, obviously, to decide how monies are spent and where emphasis is put, what you count as primary care dollars, different, that we have that experience with the blueprint. Dollars are called primary care, but they don't necessarily go to primary care practitioners. They go to primary care services and supports, et cetera, et cetera. And so really the idea of supporting, a robust primary care delivery system does need to include all those things. But, if we can't get the practitioners to the communities, it's hard to run the programs. And so whoever's making those decisions, I think, is really what's going to determine whether the AHEAD model is something more than we've been doing unsuccessfully for the last 5 years, which is really ramping up the bolstering of primary care in the state.
Yeah, right. Agreed. And so there's a certain dollar amount, but if there's so many variables as to whether or not you'll get that money, how many participants, and then there's the burden to get it. What are the bells and whistles and hoops you got to jump through to get the money? So really understanding all of that totally changes the potential value of it.
And one thing I think that relates to that is the topic of primary care spend. And we can set different percentages, but how we define primary care within primary care spend greatly changes the amount of money that's being spent on primary care. And so I would encourage you to, express your views. The whole PCAG in this through this process is because there's going to be some work as to what primary care spend is, primary care spend targets, and how we define primary care within that. But just one clarity thing on the application, and Owen, please correct me if I'm wrong, but my understanding is we applied to be selected to get development money and then enter into a negotiation with Medicare. So we haven't applied to do the model. We've applied to get essentially a grant to then pursue developing the model further and how it's going to be implemented and negotiate with CNMI on the Medicare component of that model. So it's not that if we get accepted, it's not that it's go. There's a lot of steps between here and go to see if it's going to work for Vermont and if we can make it all work.
Right, and just to orient everyone to the process, so the application is submitted just by AHS, not by the care board. And we did see it, we did comment on it, but AHS submits it. If we're accepted, we then negotiate after getting accepted. And there's two tracks. There's either the AHS off-the-shelf model for what a global budget methodology would be and how you calculate it, or you can design a state-specific. So because of Vermont's sort of experience in healthcare reform and because it has a regulator, we are allowed to get our own methodology submitted and potentially approved. So Dave and Rob and Lunge have been working on coming up with our own model, which we'll submit, I think it's June 30th. And then AHS comes back and says, no, your model wasn't accepted, your methodology is no good, or yes, it was. And we also negotiate what the targets are, what the measures are, all these other components. So, Vermont is, on a per capita basis, a low cost Medicare state. And so one of the things we're going to be looking for is, can we get some of that savings, if you will, back? Can we get more money from Medicare? And if we can, that makes the model more appealing. If we can't, it's a different calculus. So all of these things in terms of like whether our methodology is more favorable for the state, whether it gets accepted, how much money we get through this negotiation. All of that has really big implications. Then also, if you think about the Blueprint and SASH money, can we continue that? Can we get out of MIPS and MACRA? Can it be MIPS and MACRA light? Can we get the same things if we go in cohort 2? So some states are applying not in the first cohort, this first for 2026, but for cohort 2 or down the road. And so trying to understand all those variables is what we'll be working on.
And Owen, just for the record, I know you meant to say CMS and you said AHS. So CMS will decide, not AHS. It's been a long day.
Sorry, yes.
Eileen.
That was very helpful discussion and outline of kind of the thinking, the process. That was really helpful. So my question is the comment about identifying what goes into PC spend as well as what is the spend and giving some feedback. We all know that the amount of the primary care spend, we all want to be huge. So I don't think where the feedback needs to be. It's more what should be included or not be included in that to define that. Where should that go? If we have thoughts, what are you looking for and where should we send those thoughts?
So, Owen, you might want to chime in here, but we will make sure we get you.
Hey, Susan, your
audio. Yeah.
Your audio's doing the thing, but now it sounds okay. So try again.
Owen can do it. Owen, you answer.
I think the best place is to send it to both AHS and the Green Mountain Care Board. Really on your evaluation of the opportunities for primary care and the funding that's supposed to support primary care, and also what the burdens are and the risks are to get that money. So the negotiation team will be AHS and the Green Mountain Care Board. I think it's 4 of us. I think it's Secretary Samuelson, Pat Jones, myself, and I think Robin Lunge is, I think, what they've defined as the negotiation team. So I think if any one or the 4 of us get it, that would be really good. Although I'm uncomfortable of having identified myself as part of the negotiation team, because if it's not very good, you know who to yell at.
Yeah.
Can you
Question.
guys hear me? Oh, go ahead, Paul. Sorry.
Yeah, no, I think sort of percolating along that we really haven't addressed, at least I haven't heard addressed. My real concern is the transition time here, the transition year, when the current model ends and before something else starts. It could really be disastrous for primary care. I don't know how we're going to survive without any source of additional funding. I'm not quite sure how that's going to happen, or whether, I mean, I'll just throw out there may need to be a legislative solution where there's funding in the meantime somehow, to keep practices supported during that interim time. Is there somebody or some group talking about this?
So if we're accepted if we go forward with the plan and it's 2026, we're currently negotiating and evaluating an opportunity to continue the current model in 2025. So if that's successful and the ACO chooses to continue on, we'll not have a gap. If we're unsuccessful in negotiating with CMMI for that extension year, or if something changes with the ACO, there could be a gap. But I think right now everyone's aiming and working pretty hard to make sure there isn't a gap. Now, if we do the second or third cohort for the AHEAD model and the ACO weren't able to continue, and then we had 2026, you know, not because of the ACO, but because the feds wouldn't let us keep getting the same terms, then there could be a gap. I know in one of the bills, there's been a lot of bills in the legislature that I've read, so I forget where they were, but there was a primary care spend target in one of the bills. These bills are changing like a lot. Like you come back on a Monday and all of a sudden it's like different. So I know there was a primary care target of 12% in one of the bills. And I think Dr. Murman was talking about this, but how you calculate what's primary care, and Dr. Rice, you said the same thing. It can be 3.5% in Vermont, it can be 7%, or it can be like 10.5%, depending on what methodology you use. So it can really change it. I have told legislators that I think that those targets are probably wise and a really good thing given where primary care is. So I would probably encourage you to lobby and speak with people about that need, particularly if the funding in the HEAD model is less than what you're currently receiving through OneCare and CPR, or even if we have a gap. I know that part came out, I think it was like a Medicaid, an increase in Medicaid payment, and it was prioritizing primary care. I think it was in Senate Health and Welfare in one of those bills, and we could probably find it for you if you want to look at what it had been.
I think the targets were in S-151.
151,
That was gonna
yeah.
do the primary care spend.
Yep. But that didn't make it out of committee, so, but we can send it around because it might reemerge in other bills on the House side, so. Okay.
Stephanie, was that the same, was it the same bill that had the prioritizing Medicaid to pay the same as Medicare, but with primary care first? Was it the same bill and it just switched, or were they different?
Yes, that was also in 151 where it said 100%, and we wanted to change it to 110 because we're at 110 now, but it really didn't matter that we wanted to change it since that bill was dying. But yeah, it was in 151.
I'm not like a legislative pro by any stretch. I'm learning this every morning practically, but I don't know if you can put it in somewhere else if you were interested in lobbying it for it elsewhere. I don't know how that works. But if I recall, I think the primary care providers may have an outstanding lobbyist named Christine McLaughlin, and she would know.
Right. Okay. This was great. We'll follow up with, as Owen suggested, once we get a process for discussion. As I said, we have been discussing the HEAD model, but we're really going to be getting in more into the weeds, and we'll have a very laid out process that we can share with you. And it's taped too, so if you can come to the meetings, we have our own YouTube channel, and we'll be checking in with you for input. So thank you all very much. I know Elena can talk really fast, but this is relevant to Canada Hospital budget guidance as we speak. The big part of the HEAD model is global budgets. So, you know, we want to hear from you as Elena goes through her presentation tonight on some of the areas we pulled out of current guidance, but also as we look, not to use the word again, ahead and evolve the process and how, given your context as primary care providers, I think that will be really helpful. We got some call out questions. So go ahead, Elena.
All right. And I'm going to share my screen. So just a moment. And I'm going to try to do the skinny version, as Susan mentioned. So I might go quickly through things I would otherwise spend time on. Can you see my screen? Okay. All right. So as Susan mentioned, I'm just going to give a quick update on the global budget guidance. These are all posted to our website. So if you do want to get into more detail and provide feedback, our public comment period is open through the 25th. or if you even have ideas after that, I think we're always accepting public comment. So, even thinking to next year and beyond. But we will spend some time at the end talking about kind of thinking forward. So just quickly, when we talk about hospital budget guidance materials, these are kind of like setting the rules of the game in advance of the submission of hospital budgets to the board. So we have the guidance document that specifies how budgets will be evaluated. So that's where I'll spend most of my time talking with you today. There's also a uniform reporting manual that has standard definitions for financial, and hopefully in the future we'll have non-financial reporting definitions more clearly articulated there. This is an area that I'd like to spend more time. It gives us a better apples to apples comparison across hospitals and make sure we know we're all talking about the same thing. We also this year published a hospital budget review measures inventory. This is really kind of like a data dictionary. We don't set benchmarks for these measures. They're just kind of defining measures that we've either used previously or have come into the conversation or kind of industry standards. But this is so we can kind of, again, have some shared understanding of what we're talking about and how these measures are created. And we'll spend a little bit of time on a couple of the measures included there for your feedback. So this is just, some goals that the board had when establishing the guidance was really to make sure that it is both predictable and adaptable. So we want to be able to, say what we hope to set expectations clearly, but also recognize that there hospital-specific challenges, a dynamic industry and economic environment, and that may require some deviations from the predictable targets that we set in advance. The guidance structure, so we kind of revamped it this year to kind of have more transparency about what we're looking at and how we're measuring things and what we use certain measures for. If you'd like to go into more detail, like I said, it's posted, but this is kind of the structure. So we have the introduction, how the budget process works, other kinds of timelines and submission requirements. Section 1 establishes benchmarks against which budgets will be evaluated. Section 2 has a series, describes some comparative analytics that can be used to evaluate budgets if they don't meet the benchmarks in Section 1. So there may be a reason why a hospital needs to request a higher NPR or asks for higher price growth. And so, that's really thinking about telling the broader picture of what's going on locally or for a particular hospital. Section 3 is budget assumption. So what kinds of assumptions are inherent in the budget in terms of Medicaid rate increases, utilization, and other kinds of factors, like payer mix, patient acuity, those kinds of things. So we know kind of what's changed from year to year. And then Section 4, we took a shot at trying to kind of incorporate this broader picture. So bringing in more systematically contextual information for better understanding the needs of a community, which would highlight, delivery system pressures from outside the hospital, or, for example, insufficient primary care access. So that's where we'd look to you for some input. I highlighted a couple of the measures that are in that measures inventory so far. But would certainly be open to hearing other ideas you have for things that we may have missed or that we should think about in context of the hospital budget process. Section 5, every year we have a narrative, so for hospitals to provide more color as to what's going on in their community and kind of strategies around their proposed budget. And then Section 6 is the details of hospital reporting requirements. So the decision tree, so as I mentioned, those Section 1 benchmarks are kind of the key to the budget review. So we look at the budget submitted relative to those Section 1 benchmarks. If they meet the benchmarks and the budget assumptions appear reasonable, like they've modeled Medicare and Medicaid rate increases and didn't assume, zero for everything, for example, then we would expect to approve the budget. We'll still do a review, comparative review to kind of look under the hood and just see what else is going on in case we have questions, but largely we wouldn't expect to adjust the budget if they met all those requirements. If they do not meet the Section 1 benchmarks, then we will still review the budget assumptions, but then we would kind of maybe, look across some of these comparative measures to understand what else could be going on, and then consider adjusting the budget from there. Okay, so the section 1 benchmark, so there are 3 of them. It's net patient revenue growth, which has been kind of the standard that the board has used for many years. And then I'll talk about the 2 others that we've added this year. In line with the state's all-payer model agreement, board and staff members have talked about establishing a net patient revenue growth target that is between 3.5% and 4.3%. Board members asked us to go back and pick one and propose one, so that's what we did this week. And then the expectation is that any hospitals exceeding the benchmark would be required to justify, why they would need more NPR relative to this growth target. And some of the, data on our growth over the last several years look kind of like this. So what you're looking at here is NPR growth. The trended lines, the green, the orange, and the blue lines are trended from fiscal year 2017. The green dotted line is NPR with a 4.3% growth rate. So that's total net patient revenue for the hospital at 4.3%. The orange line is net patient revenue from 2017 trended at 3.5% growth. So that's if we grew from 2017 at that rate, what would we have? Where would we be today? So to the right, you can see if we stayed at 4.3%, we would be at 3.43 billion in 25. If we stayed at 3.5% growth, we'd be at 3.22 billion. So that's kind of in that box below. The furthest right column is approximately, half a billion, or yeah, so $500 million. If we stayed at 3.5%, or approximately $300 million if we trended at 4.3%. But what you can see is that we've greatly outpaced that growth rate over the last several years, and we've been, cumulatively around 6% over that period of time.
Elena, can I interrupt? Because the board just had this presentation today, and it took me a little more time to kind of grasp things. So I just wanted to make sure for everyone who hasn't been through this already, do you want us to slow down, or is this okay? It might just be me.
It's a lot of information.
Right.
Okay. I'm happy to come back as we kind of introduce more ideas and
yeah, and Elena, sorry, I hope you guys can you hear me? If people have a question, just raise your hand. We forgot to say that at the beginning.
I'm sorry. Yes, this can be a conversation. I don't want to talk at you the whole time. I want to get your feedback too. So I'm just setting the stage. Okay. All right. So, one thing that we'd hope is that some of this growth would be about increasing access. If we look at, and I'm skinning this down, so in many ways we can look at this. There's no perfect measure. Volume's really hard to kind of summarize in one measure, but it's been pretty flat over a period of time. We don't have more recent data. So this ends in 2021, but basically what you see is it's pretty flat. There's a dip during COVID, and we're kind of back up where we were before. But then, so, what's explaining this growth? A lot of it, you can kind of see that we added this actual operating expenditures line that shows that operating expenditures have been growing proportionally over this period of time. And so we received some feedback that we should really be digging into the drivers of that. And that's what we hope to do through the budget process, which is really great point. If we look at operating expense growth per adjusted discharge, so like thinking about, how much we're growing relative to how many patients we're serving. Again, these are kind of directional measures. There's Vermont is this yellow line here. So you'll notice we kind of hang with Maine relative to, the other New England states. We are an aging population, but, New England is, also aging. And so, but that, these are real dollars, and it's just something to know and dig into. So, and it has been a substantial increase from 2017. And this translates into price growth. So we see through charge growth over time. The green line is operating margin. So your revenues less expenses. This is, we know that some of our hospitals have had challenges with their financial health. And so, you can see prior to 2020, we were okay for a period, and then we had this decline, and then have been bouncing around since, but you can see a spike in charge growth over time. And so I think, staff recommended that we really hold the line at 3.5% and, to try to bring us back down, that we can't continue to grow exponentially when we're also trying to invest in primary care and other areas. And so they're contemplating this before next week. The second benchmark is the commercial rate growth. So hospital charges less the negotiated discounts. And so this year we are planning to set a target, our benchmark for hospital budgets. We contemplated a series of inflationary indices, and I will skip over all of a lot of the detail we went into today, but I'm happy to, you can certainly watch that presentation or dig into the details if you'd like, but we proposed an index that is similar to a lot of these other indices, but is really about personal consumption. So what consumers can afford. And we compared that to other metrics such as the CPI, which is another consumer kind of based metric, Medicare market basket, and a personal health care deflator used by the National Healthcare Expenditure at CMS. So, it's a pretty conservative measure. It's higher than a lot of these other measures. And we thought for the first year that we're setting a target in advance that, and it's a lagged target, that it would give more flexibility, but still be, as you'll see here, conservative relative to the growth rates that we've seen in Vermont over time. So the blue bar here is the charge growth that our hospitals, the orange bar is the charge growth that our hospitals experienced, and the price index is the blue bar. So it's a price index plus 1%. So you'll see that it trends with the charge growth over time that we've experienced in Vermont, but is less. And this wouldn't mean this is like all hospitals could charge. It's just a starting place. So, we would kind of evaluate all those budgets, and hospitals would be required to justify any price increases above inflation. So this amounts to 3.4%, and the cap would also apply to individual commercial payers or the major commercial payers. So that we don't have cross subsidization, the board had expressed interest in making sure that any rate increases that are applied are done so in an equitable manner. The third benchmark that we propose this year is for hospitals to submit budgets with operating margins greater than 0. With rising inflation and many of the other pressures, its burden is on the hospital to make tough decisions about how to manage expenses, and we'd hope that an efficient hospital would be able to manage those expenses, or we could raise more systematic issues that we have to address as a state. That is also part of this process, is to learn about those pressures that hospitals are under. So the comparative analytics section, as I mentioned, are those factors that are used to further analyze budgets, particularly those that don't meet the Section 1 benchmarks. We're not setting any benchmarks in advance. This is really, many of these measures kind of describe how a hospital is operating. And, there's not really a perfect formula, but you need to kind of look at them together to understand the broader story of what's happening. Some examples of these measures. So there's a screenshot on the right of a hospital budget review tool that was developed last year. So it's kind of taking a version of this, but we're still working on the visualization piece of it. But it'll have, different kinds of measures that look at revenue trends, operating efficiency, and hospital financial health. And so if you do start perusing the hospital budget review measures inventory list, the measures for this section are labeled Section 2. The budget assumptions, so I just throw this up briefly here, some of the budget assumptions I discussed earlier that we'd be looking for. Section 4, the contextual information. So those measures are also included in that measured inventory list, but it's really about, what are the other insights that will round out our understanding of what's happening in a community and pressures the hospital is facing. And so we had a question for you here. In the subsequent slide, I pulled out some of the measures from this section. So, that we think are important for understanding warranted or unwarranted hospital utilization, but wanted to get your feedback on measures we should be thinking about to understand the broader context. Again, these are just a subset because there are a lot of measures we think are important that describe patient health status, kind of community demographics, but would love your thoughts on this subset or other measures you think we should absolutely include. Recognizing that this is a list and you haven't had time to digest it, I'll just leave it there for a moment.
Elena, I don't know if you want to call on folks. Can you see that hand?
Yeah, just speak up. Go ahead, Paul.
Yes, thank you for that presentation. That gives a real sense of what you're looking at. A couple of comments. One, it seems that most things are based on percentages, but we all know the hospitals are quite disparate in where they are starting at. So if a hospital already has fees to or are paid very highly by a commercial payer, allowing a 5% increase to that hospital will widen the gap even further by allowing that same 5% to a hospital that's being paid half as much, for example. I don't know if it's that great, but I'm sure there's some significant disparities in some of the fees that are being paid to different hospitals. So I would urge looking at the actual fees at where they're at rather than a percentage of increase, because the gap just keeps getting wider in some places, I think. The other is, in general, this inability to really know the value of what's being delivered at the various hospitals by just putting a cap on the growth. We may want some hospitals to grow certain lines of business significantly if they have found a way to do it very efficiently. But we really haven't looked at that. Cost accounting is a term that gets used a lot in looking at hospitals, and we really haven't done it. I don't know if the board has the ability, but it would be great if the board started asking these hospitals to at least report, their cost accounting. What does it cost for you to see each person you see in the ER, or each hip you replace, or each baby you deliver? What is the cost that goes into that? And then you're going to really get some, I think, comparisons between hospitals as to their efficiency. Too much overhead somewhere, inefficiency in turning over ORs, for example, et cetera, et cetera. And there's hospitals across the country that do cost accounting, and they can tell you exactly how much it costs to deliver each service they deliver. We haven't looked at that, but that would be the ultimate, to know how to reward or on the other hand, encourage hospitals to become more efficient.
Thank you.
Elena, I wouldn't mind responding to Paul, and maybe I know Dave has thoughts on this topic too. So some of the other stuff we look at, Paul, will have information that gives us a kind of a mosaic of what a hospital looks like. And some of it is, what are their prices already? What are their costs already? How expensive are they? And as I go into the hospital budget process, I will be looking at that. So if a hospital wants to go above 3% or 4% or whatever it is, if they are starting from a low base, they've got a much better argument to justify their request. And there is a big range, I think, in some of our hospitals. And then sort of, I guess, as a policy matter, we do want to drive care to places that have really high quality, that are very accessible, and that are more affordable, right? I mean, if you get one procedure at this place and one over there, they can be enormously different. So we definitely want to see and have care go to where it's, should be. So we definitely, I will be thinking about that. And I know Dave will too.
I'm happy to chime in on a few comments, or if there's hands up. Maybe I'll just address one thing, Paul, that you said. I really agree with the idea of thinking about the prices and trying to understand what we're giving a rate increase to. And when we look at, it's really hard to look at pricing data. We have a tool at the Care Board. I've looked through Blue Cross Blue Shield's tool. And then there's the various RAND studies, which I think are probably the most helpful because they aggregate it all into, a standardized price for, well, in 3, it's inpatient, outpatient, and 4, it's a % of Medicare for all services, I believe. And there's huge variability within the state. So I would agree with you. I think there's certain hospitals that if you give 5% more to a hospital that's, say, 200% of Medicare, that's very different than giving 5% to a hospital that's 300% of Medicare. That's just a lot more. That 5% to 300% is a lot more dollars. And so we're trying to think of that. It's there isn't a perfect tool for looking at baseline pricing, but I think things are getting better and better. And Paul, you have your hand up, Paul, and then Elena has her hand up. If either one you want to go, I don't know if Elena has more to present.
I do, but I'd love any other comments, and then I just have actually more questions for you at the end related to this topic. But Eileen, do you want to share your thoughts?
It's interesting that a lot of us are either thinking or speaking the word that what are things based on, which just reminds us what is the base that we're basing it on. So I just think of that as I'm listening to people. My thoughts on this, it's hard to put everything into this brief of a statement, so it's well presented here. I think of with the long ED stays and preventable hospital stays, what we've talked about in this group before is how do you measure things that didn't happen? Not just did they go to the ED when they could have been seen in primary care but couldn't for whatever reason, or were in the hospital and that could have been prevented. Well, how do you measure the ones that did not go to the ED and didn't get admitted because we were able to take care of them in primary care and prevent that expense? So that's always a hard one to come up with. How do you look at that? I think your primary care providers rate probably just is missing APRNs in there, since it only has physicians and PAs. And then the other one was when you're looking at primary care, I think this is a little bit related to the primary care spend, is who's included in primary care. So one of the things we think about is mental health could include opiate use addiction clinics, mental health versus primary care. They're actually both. Diabetes clinics, those kind of things. What is actually in primary care as far as these numbers? So again, this relates to other stuff, just things to think about. Thank you.
Great, thank you. All right, Tim.
Some weedy comments and then a more general comment. There needs to be a functional measure for mental health counselors in skilled nursing beds. Around here, there are lots of counselors that are listed in a registry, but a much smaller percentage are accepting patients. So how many counselors are actually accepting patients? And the same kind of thing for skilled beds. The nursing homes may have beds, but they don't have nursing staff. So there are beds that are empty. So it needs to be sort of a functional measure, not just a count. And then a more general comment is I'd like to see something in the section 4 that allows hospitals, again, putting a plug for this family practice residency program, to be able to account for that somehow in their budget, because it will cost.
Thank you. Carrie.
Thank you. Similar to what Eileen was saying, I think we're missing preventable ED visits here, potentially avoidable ED visits, which is something that is measured, and I think it's a big sinkhole for cost. And it also speaks to availability for primary care. We use the word access a lot. I like to think about availability. So if I'm available at 6 p.m. at night, maybe the patient won't go to the ED. I think there's a lot we're missing if we don't measure that. And then just something else related to your primary care, what's in the primary care spend. I am in favor of considering long-term nursing home patients in primary care. I know we kind of separate long-term care nursing home residents out into a separate group, but I really think they are our primary care patients and should be included.
Would you look at all of their care as primary care or just the provider associated care as primary care?
All of it except for specialty care when needed. You know, rehab in a nursing home would be different. But I think when I go and visit the rest of the residents or patients that I've seen in the outpatient world who now live in the nursing home, they're still part of my patient panel. And I think they are still a primary care patient, essentially.
Okay. Okay. But so not the expense associated with them living in the nursing home.
The facility,
not,
correct.
Okay.
Not that.
I
so much,
would
no.
think we just need to then think of a very high primary care target if we're going to include the
Yes.
facility expenses in there.
Gotcha. Yes, I agree.
Great. Great. I totally agree. Thanks.
Great. Well, these are wonderful comments. And, you know, some of the challenges is finding the data, collecting the data. So we're largely relying on existing data sources, but, you know, I think having a list of what we would like to have could help us think about other ways, creative ways we can find new data sources. I'm going to keep going so we can get to some of the other questions that you guys have touched on, but I'd love to hear more. So I won't spend time. There's a narrative. If you want to know what we're asking there's some questions there. Actually, here's one that I pulled out for you. You know, given the access challenges related to mental health, substance use disorder, long-term care, and primary care, please share any investments you are making and the steps you're taking to improve access in those areas with specific ties to your budget. So this is a question to hospitals, but, you know, wanted to ask here, you know, if you have thoughts on this, or how we might strengthen this question. You know, what should we expect to hear? What would we hope to hear if we were
I guess I would say that one thing that would help with mental health and substance use disorder is just so is the question, Alina, what should hospitals be saying about how they support these things?
Yeah, what do we think the hospital's role is in supporting these things? And certainly I imagine it would depend on if they own primary care or not, or, you know, other things, but are there kind of, you know, is this a better question to discuss and, you know, and not have a narrative response? I'm not sure, but just wanted to put it out there. Lee?
Yeah, I guess my key response to, or thought about this is how much of, and the hospital would have to sort of define this, how much of this do they own? In the sense, you know, how many primary care practices do they own? And what are they doing to invest in them and in primary care in general? How many, you know, opioid use disorder clinics do they run? And what are they doing to invest in them? You know, because it's going to be very different for each hospital if they do not have a primary care ownership role, then they're going to have a different approach to supporting it. And I guess and you know what steps they're taking to improve access, there may be none, just because they don't own anything and they don't care about it because they've got enough other things on their plate to say, I really am going to let primary care make it on its own. So part of the question, I think, should be a list of what their pre-existing investments in these things are, and then what are they going to do to make it better over the long haul.
Great, thank you. Tim?
I'm still trying to get to formulate my response, but I mean, these are all loss leaders for the hospital. So how do they divert money from their profit centers to these loss leaders? And has that percentage of their budget stayed the same, gone up, or gone down?
Thank you. Eileen.
I also think about access and knowledge of what's available in the area. So sometimes with a loss leader, if you're doing enough volume, it may not make up, but at least you've got the volume going and that helps. But how does that get communicated to primary care or other referral folks to some of these options available? How do you know about them and how to use them so they're not underutilized when they're really needed?
Thank you. Faye?
What I was thinking about here was, what I need from the hospitals my patients go to in primary care. How could the hospital help me do a better job? And it's going to sound like a lot of stuff that we've talked about here over and over again, but reliably getting records to us. I often don't get specialty records, often don't get ER records or get partial records. So just really good communication showing that they value what primary care is doing would be a start. One of the things that gets in our way for seeing patients promptly after the ED or even keeping them out of the ED is that we have to keep our schedules full for financial reasons. And, is there a way for us to collaborate with hospitals so that we can keep something open so that they can have the patient have follow-up the next day with us? It's that the pressures for us to stay busy are at direct odds with keeping people out of the hospital. And so can the hospitals collaborate with with us on that in some way? And the other thing that I think somebody else, maybe Eileen was alluding to, is there's all these resources in the community to help patients who are having problems, who are in the ER. And I don't think our EDs do a very good job of connecting patients to substance use disorder, to mental health, to finding a primary care provider if they need it, to all the other supports there are in the community. I think better social work in the ED would make a difference too.
Thank you. Okay, Dave, you have something to add?
I gotta just do my little ED comment because, and I think this is something that in my practice has changed so much over. Well, that's not true. I actually did residency in a place that had remarkably good social work in ED, but I work in a place now where I have really great access to social workers, recovery coaches. We, at least in my ED, we really spend a ton of time trying to work through these issues with social workers, with recovery coaches, get primary care providers, try to use back doors to get primary care providers, try to use front doors to get primary care providers. So I'm lucky because I work with a really wonderful group of people. And it may not be the same in all EDs around the state, but it's something that I think as a at least in Vermont as a profession, it's something we really pride ourselves on, but we definitely would love to do better too. So that's the ED Dave, not the Care Board Dave. Sorry, I had to give my little ED plug. Thank you though.
And Elena, I'm going to shut my camera. I'm just doing a time check here.
Yes, we have 5 minutes left. I'm gonna just skip to the end, which we had some other questions, which I think we've touched on a little bit, but there's a lot here. How should we think about primary care investment in the hospital? This is more forward looking. I think this would require substantial overhaul to how we do some things, but would start to think about these things. But how would we think about primary care investment in the hospital budget review process? How do we track dollars flowing to primary care through hospitals? How should we think about equitable reimbursement between hospital-owned and non-hospital-owned primary care? And what else, if anything, can the board do to support increasing primary care access through the hospital budget review process? So I think we've touched on a lot of these things, but any other kind of concluding thoughts you have for us would be great to hear now or after this meeting.
I will just say, sorry, I didn't raise my hand, but these are great questions, and this hits on what so many of us have been speaking about. So even just asking these questions is a good thing.
Great. Thanks, Eileen. Lee?
So the one thing I would say is just from experience, and it's a long time ago, so it may not be going on this way anymore, but one of the things that drove me crazy when I was working for a hospital system was that they had budgets for us that charged us rent on the buildings. And that's all well and good, okay, but they didn't charge the surgeon's rent for the OR. They didn't charge the, Dave, the ED doctor's rent for the ED. And so we were getting charged something and being told, oh, well, you're losing money. Well, we were, but only if you charged us for things that other people that work for the hospital or are employed by the hospital don't get charged for. So we have to make sure that we're comparing apples to apples when we compare primary care spend or primary care dollars flowing to primary care as compared to dollars flowing to other specialties.
Thank you for that. Carrie?
Very similar to what Lee just said. I will be bold and state I think it would be great if the Green Mountain Care Board would hold hospitals accountable for reporting what they spend on primary care.
Thank you, Carrie.
Would you be willing to detail that a little bit more as to how you think spending on primary care, what is included in that?
Well, I do think that would have to be defined first, as we've already discussed tonight. So I think that would take some work.
Yeah.
And I think this is a perfect group to help you with that. We've given you a couple of ideas tonight, but I think it might take a little time to define that.
Yeah, the NESCO definition is sort of what's being thrown around as a definition that we could use that gives us a comparison group.
Mm-hmm.
But it does give a pretty robust number for total primary care spend compared to some other definitions, which is, I think, becomes very complicated in trying to choose then the right percentage target.
I grant that it's complicated, but I just still think we could do it the Vermont way and figure out our own formula.
And Carrie, it sounded like what you were saying is what hospitals spend on primary care. So it's kind of that throughput. Yeah.
Yes.
I appreciate that. Paul?
Yeah, I would be volunteer to assist with such a project, David, if you have an interest in that. I mean, I do think that for whatever reason, it costs a lot more money to deliver primary care when a hospital owns it than it does outside of a hospital. And despite tremendous amounts of funding for, to some extent, free labor in residence at one hospital, but also grants and subsidies and payments for being a teaching hospital or nonprofit status, for example. The buildings and the income is not taxed at all in the hospital systems, but it is in the real world. And so if you actually do look at what the cost is to deliver care to each individual patient that you have as assigned as a primary care, that would be great data. I'd work on that project if somebody's interested.
Great, thank you. Well, sounds like we'll have to take some volunteers. That's all I had for you. I want to be respectful of your time, and I'll pass it back to Susan, but I'd love to hear any other thoughts if something comes to you after today.
Great. Thanks, Elena. I took my camera off. We can open it up to public comment, and I said hello to him, Andy Barter, but I didn't introduce him. I introduced there were a few folks that I called out at the beginning of the meeting. So I see Andy Barter's here still. He's the CEO of Little Rivers Healthcare up the road from me in Bradford. So thank you for coming. So any public comment or any other, let's start with public, like for folks who are not on the PCAG. Hear any? Okay, anything else from the PCAG? This was a great meeting. Thank you so much for all the information. Really helpful.
And Susan, I might just
There is
chime
a
in.
group,
Oh, sorry.
if there is a group of people that are looking at what goes into primary care and primary care spend, I'd be happy to participate in that if that actually moves forward, depending upon how you want to do that.
Thank you. There's some history there. It has been done once already by Michelle Degree and Diva, someone from Medicaid. So, but we'll definitely keep you guys in the loop, and thank you for volunteering for your help. Julia, you were going to say something?
Yeah, I was just gonna chime in and recap to folks the notes that I've been taking about the things that I'll send in a follow-up. So from our first part of the discussion, we'll send out that press release from AHS that I mentioned, links to where you can send public comments, and then once the board has more public meetings scheduled, I can keep PCAG posted, and also we always post our meetings on our website, so you can keep track there. But we'll try to flag those for you. And then on the hospital budget guidance, we'll send out Elena's presentation. I know we didn't get that posted ahead of time, but I'll send that out, a recording to this meeting for the folks who couldn't attend, and then also a link to the public comment period. Again, if you just go to the Green Mountain Care Board's main website, it's like the first button is public comment, so it's pretty easy to find. But I'll be sending all that out probably tomorrow once I have a chance to upload the recording from us talking right now. Yeah, and if anything else, if people think of anything else, of course, you can always email me. But yeah, go ahead, Owen, or I'm done.
I just had two quick things. A few folks on this meeting last spring, I think it was, and maybe fall of 22 or winter of 22, helped us with a couple of primary care provider board meetings specific on what steps can be taken to support primary care and bolster primary care in Vermont. And they're really productive, and we had a whole set of recommendations. So if people didn't get a chance to see those or review the materials, we can point out those. There's a lot of ideas I loved, and I know a lot of board members loved, but some of them were challenges of authorities, right? Like we can't create a program to reimburse for tuition for primary care, but that doesn't mean it's not a really good idea and should just be left. So I'm worried a little bit that some of those, what I thought were really fruitful discussions and good ideas, are kind of like now left in history and they're not being pursued. So I wanted to flag those as something for people to take a look at in the legislative session or just in other opportunities to get those done. The other thing I'd say is the board, myself, Elena, Dave, the other board members, everyone, we're really focused on primary care, and we're trying to do what we can, and we're trying to add our voice to support primary care as much as possible. So I want to flag a couple things we've done just so people are aware that, what we're doing. One of the things that's kind of gone unnoticed was what we did in the rate review hearings for insurance companies. And we put in a provision requiring the insurance companies to award rate based on quality, access, and affordability. So we had learned in the rate review process that there was kind of two distinct negotiation processes with insurance companies, one for hospitals, one for everyone else. And they weren't really being driven necessarily by quality, access, and affordability. So we required them to do that, and they very willingly did. They didn't appeal, they didn't complain, they're doing it. And so I wanted to flag that as an effort that we did. With OneCare, I know we have Dr. Wolfman here too. We've taken a number of steps. We've worked with them. We've required things to be done to ensure that primary care supports the CPR payments. That was a board ordered thing to make sure the CPR payments continued after the Blue Cross withdrawal. We've tried to get more information about how the primary care money through OneCare was being used at hospitals. And I think Dr. Wolfman's point was really great, and I agree with it, and we'll be doing it, seeing how money is being used for primary care at hospitals and hospital budgets. We're going to do that. So we've also spoken publicly a bunch about these things, and we're really willing and amenable to doing whatever we can to support primary care in this state. So please continue to engage with us as much as possible, and wherever we can, we will really seriously evaluate things we can do to make it better. I think it's really important. So thank you all for being on this and giving us all this feedback all the time, because it helps. I got a clap. That's funny. I got a bunch of boos earlier today, Paul. Thank you. I needed a clap.
Can I just say one more thing that's kind of indirectly related to primary care reimbursements, but I think is something that we all really care about, is making sure that people can afford health insurance, especially at a time when rates have been going up so much, is that through the urging of the healthcare advocate, we changed a technical rule on how we get what's called silver loading, how we get federal subsidies for insurance plans that are purchased on the exchange. And the estimate is this change should bring in about $40 million more federal subsidy for subsidized health insurance plans in the state. So it's a pretty substantive amount that I think will really help people be able to afford their premiums who get subsidized plans. And I don't know, it's one of those little things that kind of flies under the radar, but is really, really substantive. That said, if you do find that you have patients that have unsubsidized silver plans, they should really check to make sure, because those plans are going to look deceivingly expensive. It's a weird way that this subsidy is awarded. So definitely there's a little risk in people getting stuck in plans later that will go up in price substantially when they could get a cheaper plan with a better benefit.
Eileen, go ahead.
I just want to say thank you for that. We have a healthcare advocate group that advocates so strongly and so well for residents in this state. And this is how we find out what has happened in response to their requests. So to circle back, a thank you to you for putting that back to us and letting us know of those changes.
Alrighty. Anyone else? Julia is really good at keeping all of us on time. It is 6:59. So thank you all. And thank you, Alina, for coming. I think we lost, oh no, she's still there.
I'm here. Thank you all. Very nice to see you.
Okay.
Take care.
And we'll see you in a
Thanks,
couple of
everyone.
months. Thanks,
Thank you.
everyone.
Good night, everyone. Thank you.
Thank you.